For the ligamentous instability test, we'll stabilize proximal to the joint, the DIP, with one hand and then grasp the finger distal to the joint with the other. The DIP joint is basically an extension, and then we're going to provide a valgus and a varus stress both ways. And then we can move the joint into about 30 degrees of flexion and then do the same thing. That's the DIP, and then the PIP. Your extension, valgus and varus forces, slight flexion, same thing, to test the integrity of the collateral ligaments. For the Gamekeeper's thumb test, one hand will stabilize the metacarpal proximally, and then the other hand will provide a valgus load to the first MCP joint, stressing the ulnar collateral ligament, looking for valgus movement greater than 30 to 35 degrees. For Reagan's test, one finger will grasp the triquetrum while the other will grasp the lunate, and we'll move this in a palmar and dorsal direction. With respect to the triquetrum, positive tests would be laxity, crepitus, or reproduction of pain symptoms during palmar and dorsal movement. In Murphy's sign, I would have the patient make a fist, and then you would assess the distal alignment of the metacarpals. Typically the third one projects further than the second and the fourth ones. If they're all about the same, then that would indicate a lunate dislocation. For the TFCC load test, we'll stabilize the forearm with one hand and then move the wrist into ulnar deviation with the other. And we're going to apply an axial compressive load through the fifth metacarpal bone towards the TFCC. Positive would be pain, clicking, or crepitus within the area around the TFCC. For the thumb grind test, the examiner will hold the first metacarpal with one hand and the scaphoid or trapezium with the other, and then apply an axial compressive load, rotating the patient's first metacarpal around. A positive test would be pain or crepitus with this movement. In the Finklestein test, the patient will make a fist with the thumb inside of the fingers, and then I'll apply a compressive load into ulnar deviation. Positive test would be pain over the APL or EPP tendons within the snuff box. For the Bunnell-Litler test, the MCP will be held slightly extended, and then we'll move the PIP joint into flexion. Then we'll slightly flex the MCP joint and again move the PIP joint into flexion. If the PIP flexes further, that's indicative of tight intrinsic finger muscles. For Tinel sign at the wrist, we'll tap the volar aspect of the patient's wrist right over the area of the carpal tunnel, looking for symptoms of tingling, paresthesia, or pain over the median nerve's distribution. So for Phalen's test, we'll have the patient rest the elbow on the table, and then we'll move them into wrist flexion, and we'll hold this position for about 30 seconds looking for numbness or tingling along the median nerve's distribution. For the carpal compression test, we'll apply pressure with both thumbs evenly over the median nerve at the carpal tunnel for about 30 seconds, looking for reproduction of pain or symptoms from the median nerve that are distal to the carpal tunnel. For Froment sign, I'll have the patient try to hold a piece of paper between the pad of the thumb and the radial side of their index finger. This would be a negative test because there's extension at the DIP joint. A positive test would be inability to hold the paper because the DIP joint would be flexed instead in the patient. For the Allen's test, I'll have the patient's forearm supinated on the table, and then they'll make a fist 5 times. I'll apply compression at the radial and ulnar arteries, letting go of one, and then looking for refill. We'll go back to making a fist 5 times. Hold, and then I'll let go of the ulnar side, watching for refill.